right. Hello, everybody. Good morning from New Haven, and a good evening to those of you guys joining us from Beijing and in China. Very excited to have everybody join us. My name is Devin Lau. I'm the Assistant Director of Yale Center Beijing, and we have here with us today Dr. Saad Omer. Very excited to have today's talk. Of course, the reason we're doing this talk on Zoom is, of course, because of COVID, and we've been doing these online Zoom talks now for over 2 years now. And so it's very good to sort of take a step back and be able to reflect on why it is that we're doing these Zoom talks. And so that's what we're doing today. For those of you guys that are joining us for the first time, Yale Center Beijing is Yale's only university-wide center where we host Yale professors and thought leaders from around the world on subjects across the disciplines. Everything from economics to science to art to music. And today we're very lucky to have Dr. Saad Omer join us. He is the inaugural director of the Yale Institute for Global Health, and he's also a professor of medicine, infectious diseases at the Yale School of Medicine, and the Susan Dwight Bliss Professor of Epidemiology of Microbial Diseases at the Yale School of Public Health. Dr. Omer has conducted studies in the US as well as multiple countries across South America, Africa, Asia, and Australia. His research portfolio includes epidemiology of respiratory viruses such as influenza and, of course, most recently, COVID-19. He's done clinical trials to estimate efficacy of maternal and infant influenza, polio, measles, and pneumococcal vaccines, as well as trials to evaluate drug regimens to reduce mother-to-child transmission of HIV. So a very broad portfolio here. His work has included public health preparedness strategies to effectively respond to large emerging and re-emerging infectious disease outbreaks, and it has been cited in global and country-specific policy recommendations, informed clinical practice and health legislation in several countries, and of course been cited in popular media. He is a graduate of Johns Hopkins, and he's published over 400 papers in peer-reviewed journals and mentored over 100 junior faculty, clinical and research postdoctoral fellows, and PhD and graduate students. And today, a very timely discussion for me personally, because I actually just caught COVID over the weekend. And so, I was actually quite strangely excited to have this talk with you and glad to do so over Zoom instead of in person. So I guess I'll just start. I remember last seeing you about 2 years ago when COVID first broke out, and that was back in early 2020. And Yale had put on a panel with yourself and Sten and Albert Koh, who actually gave a talk here at Yale Center Beijing in person right before COVID broke out, I think in probably September or October. And he said, we should get ready for a global outbreak of a new emerging disease that we've never seen before. And we had no idea at that time how prophetic his words would be, because within a couple months, that's exactly what happened. And so here we are 2 years later, and we're still, in the midst of a pandemic. And so I want to start with just sort of laying the groundwork here and just saying, in 2 years, what have we learned? Where are we now exactly? What are sort of, just a general sense of where we are in this global pandemic, and how are we doing so far?
So a few things we have learned. The first thing we have learned is about the virus. We know a lot more about the virus, about the disease, than we did before at the beginning. And that has taken a global effort, and a truly global effort. For example, I know that many countries like the US and Europe benefited from the data that was shared by scientists in China earlier on about the clinical features. Obviously, these data evolve, and we have had a sort of, sometimes the initial findings get adjusted as more people get infected, more science comes out, but the early insights were extremely helpful, and a lot of them have stood the test of time. And so that was helpful. Sharing of the genome earlier on, publicly and openly, in the sense that, through sort of open science fora, helped scientists develop vaccines earlier on, irrespective of the platform, to target, spike protein and all of that stuff. So that has been helpful. The other lessons we have learned that there is a role for both non-pharmaceutical and vaccine-related interventions in controlling the outbreak. A further lesson is that any sustainable control of the outbreak requires vaccines to be a part of the strategy. But the vaccine strategy needs to be adjusted based on the latest data, because each new variant has had its own quirks, and would be happy to go into the details into that. The other lesson we learned is that having technology is not sufficient. We need to work on people actually taking the vaccines, for example, compliance and the human behavior related factors. So these are a few big picture lessons, but the last lesson that I kept for it, the lesson that I kept for the end of this list, is the fact that because vulnerabilities anywhere in the world impact everyone. So emergence of new variants, if you leave people unprotected and new variants come up, it impacts everyone. And we know that Omicron is more infectious than the other ones, although on a per infection basis, it causes less mortality. But if more people get infected, means that even if it's per infection, lower mortality, we have a public health problem. And so that means that no one is safe until everyone is safe. And focusing on global vaccine access is in everyone's interest. So these are a few big picture lessons.
Great. So there's a lot we can delve into there. You mentioned that, Omicron seems to be per infection less deadly, but of course it's more infectious. Could you just maybe, so that we're all on the same page, walk us through sort of what the sort of evolution of the variants has been like so far? Obviously, when we first started, we knew nothing about the disease at all. And it seems like now, in some parts of the world, like in, say, large cities in Europe, people don't even seem to care anymore. So sort of what has been the evolution of the different variants, and how has it changed over time?
Yeah, so as the original virus was identified in Wuhan and reported in Wuhan, the current state of evidence points to a zoonotic transmission, meaning it's a bat virus through an intermediate host going to humans. There are a lot of sort of related bat viruses, etc., and there's even more evidence more recently that supports that line of thinking. And so when the virus evolved, it had certain characteristics. One of the initial interesting things was that asymptomatic people were able to transmit the virus. And there was some initial confusion in all countries. About that point, it took us a couple of months to clarify that asymptomatic transmission was a significant mode of transmission. People sort of transmitting before developing symptoms. So that was the sort of, just to go back in time a little bit. Then we had, through the spring, summer, Northern Hemisphere spring, summer, whenever I say spring, summer, my Australian and South African colleagues point to the round nature of the globe, and that all seasons don't happen in the same months, but the Northern Hemisphere spring, summer 2020 saw the emergence of the original virus. That was infectious. It was more infectious than influenza, but slightly less infectious than SARS-1, the original SARS that happened in 2003 that China is well aware of, and other countries in Southeast Asia were able to successfully control, and the rest of the world was able to successfully control eventually. But it was slightly in that vicinity, but not hugely infectious. But then what happened was we had the emergence of a new variant, Alpha, that was first identified in the UK. When the reason I'm saying is that identified is once sort of a virus spreads after the original one, and sometimes it's not even clear with the original virus, but here we have sort of evidence that points to a sort of an emergence in a sort of a finite geographic area. It's hard to say where the variant emerged, but it's just that you go by where it was reported. So the initial reporting of the alpha, the so-called alpha variant, what happened in the UK, where it was found that it was more transmittable, but equally on a per case basis, equally severe, or actually slightly more severe in terms of hospitalization rates, etc., but not hugely more severe, but substantially, so that was associated with the late 2020, early 2021 wave, which was pretty substantial. Then came a couple of other variants, one in beta and sort of in Lao, etc. So there are a couple of variants that came in South Africa, were identified in South Africa and Brazil, etc. That raised alarm, but didn't go too far. The next big variant of concern that impacted everyone was Delta, because it was not only more infectious, but also more severe, substantially more severe than Alpha. And around November, late November, it was reported more broadly, it emerged earlier on, was the so-called Omicron variant, which is a variant which it was fairly clear that it was identified in as being more infectious, but more infectious in the sense that it is evading not by inherently more infectious. So Delta was inherently more infectious than Alpha. Omicron, now we know, is slightly more inherently infectious than Delta, but it evades, unlike Delta, it evades immunity, both not just vaccine-related immunity, but also infection-related immunity. So it successfully, so there's this perception that infection-related immunity is somehow permanent, etc. No, that's not the case. In the face of Omicron, I would roughly consider it equivalent to 1.5 doses of a vaccine. And this is a very rough way of describing it. So slightly better than a single dose, but not by much, etc. So this is so Omicron spread like wildfire, and countries that had even successfully controlled the virus against, by their now well-practiced policies against other variants, were faced with a much bigger challenge in the face of Omicron. So that's in a nutshell about the history of important variants.
Very interesting. So if we kind of take a step back and understand the evolution of this specific virus over time, if we were to compare it to other viruses and other epidemics and pandemics that we've seen in history, is this a normal sort of course of evolution for a virus to go through? Is this something that we've seen before? Of normal being, how often do you have a global pandemic? But is there a point of comparison that we can have with say, a cold or a flu?
That's a really good question. Well, it's normal for a pandemic to give you surprises. Let's put it that way. Yes. So it is normal for us to not know a lot about it initially and then learn slowly about it, but it still continues to give surprises. I think when we look back in terms of what we as a global community, global scientific and medical and public health community could have done better, one thing is that we could have learned more from seasonal coronavirus spread. So they are seasonal, I'm sure people or a lot of people may be familiar that there are seasonal coronaviruses that spread every year. They may have entered in the human populations decades or centuries ago, but they continue to circulate with some frequency. For influenza, we learned from seasonal influenza in preparation for pandemic influenza. As you know, that you may know that threat hasn't gone away of influenza pandemic. So that is So in that sense, coming back to your question, surprises are to be expected. That's the paradox of pandemics. Having said that, if there is a silver lining in a way, is that we didn't get the level of infectivity of Omicron or severity of Delta as the first variant. So that gave us a little bit of a lead time to prepare for vaccines, and so on and so forth. And there's no guarantee the next one would be, pandemic would be that forgiving. So that's one thing. The other thing is, it's not surprise, but it's at the lower end of the expectation of how quickly the protection against infection. Remember, protection against severe disease still holds up reasonably well, although with Omicron, we need to have additional boosters, etc. There was some justification against during Delta as well, but with Omicron, we should specifically have a strategy for boosting, especially high-risk populations. But the fact that it is not, it is lasting, the immune memory is lasting less than we had hoped for. That's part of the surprise. Having said that, again, it's just to clarify, even against Omicron, the mortality and the severe outcomes have been overwhelmingly in unvaccinated and then unboosted populations. So that data continue to support. That doesn't mean that we should not continue to focus on sort of better and better protection, but just to clarify.
Yes, we've seen from public health in the last 2 years that it's very important to have very clear messaging here. So you've mentioned the seasonality of other diseases like the cold or influenza, and that was a question that came up with some people also. Is just, it doesn't seem like there's seasonality with COVID. At least from what we've experienced, we've had waves, but it doesn't seem like summer, winter, northern or southern makes a big difference in terms of having this disease. Is this sort of unique to this disease, or is it perhaps because we're at the very forefront of dealing with disease? What are the possible explanations for that? I guess first of all, is the observation true that there is no seasonality in COVID, and then what are some of the possibilities for why that might be?
That's again a good question. So think of it as tides and waves. So you have waves that go up and down, and then there is a tide that goes up and down. So seasonality, think of it as a wave, as a tide, and waves are you're going up and down based on measures and based on immunity, both through infection and vaccination. And so here's what has happened. So we have known, even from the first year, by the end of the first year, that there is a strong seasonal vector or strong seasonal force for this virus that supports transmission of this virus, both for environment people are indoors, but also other factors like humidity or lack thereof, and sort of other things, even somewhat temperature, etc., may impact the transmission of this virus, although the evidence for latter is emerging. But we have observed these waves that are pretty pronounced, or these sort of tides that are seasonal. That doesn't mean that inherent advantage for transmission during, again, Northern Hemisphere, fall, winter, that doesn't mean that it doesn't happen in other seasons. And this, what you alluded to, is correct, happens because they're so, in the beginning of a pandemic, there is transmission. There's so many people unprotected that even outside that most conducive seasons, there are other waves as well. So these are waves, and then the underlying tide goes up and down because of the inherent advantage in those seasons. So we have seen that before in the so-called, you may, a lot of you may be familiar with the H1N1 flu that happened in 2009 and 2010. We saw, again, an increased transmission during winter, but we also saw at a lower level, but still waves in the summer. So that's the kind of thing we expect until it settles down, and each country will have a slightly different pattern based on their seasonality and their interaction and big events like the Chinese New Year, etc., is a big gathering in China. In other countries, it's Christmas, Eid, and those kinds of things. So sometimes they impact as well. But essentially, when the virus is new, it has additional waves, etc. And as it becomes endemic, a seasonal pattern. So it may not be, let's say in the US, I expect like 4 or 5 years from now, the peak seasons to be from December to February. But that hasn't settled yet. There may be an early fall wave, etc. In the US, but that will happen in like 3, 4 years at least. We will continue to be hit by these smaller waves, smaller in relative sense. So coming back to sort of countries in Asia, etc., the influenza pattern is different by country based on various, as I said, social factors, as well as actual weather-related factors. But there will be a pattern, a more predictable pattern that the virus will settle into in a few years. That's what we expect.
That's very interesting. So it seems then that we're heading into a pattern of sort of COVID becoming more and more like what we would expect to see for a seasonal flus or seasonal colds. And that seems to bear out throughout history, that's sort of what happens with pandemics. Is that correct?
Yeah, and if it may, so in certain places, the even seasonal viruses have more than one peak, but it does become a more predictable pattern. So it depends on the country, as I said, what that pattern is somewhat, and based on various factors, but it does settle into that pattern.
Very interesting. And so I guess with that, then there's a lot of questions, right? Because what we've observed is the first couple waves, obviously the mortality was very high compared to where Omicron is and things like that. So is that also sort of typical? And is that just because of quote unquote herd immunity? Like that the variants seem to be a little less deadly over time? What are some of the possible explanations for what's going on?
So a little bit of a nuance there. So the way viruses, these kinds of respiratory viruses evolve is that for a virus to spread, it has to be either inherently more infectious than the previous variant to outcompete, or better at evading immunity, natural as well as vaccine related, depending on sort of what is the source of immunity in a population. So that is more and more into the direction of, more infectivity generally, or outcompeting other existing variants or immunity against those variants. But unless a virus kills so many of its hosts that it reduces diminishes its ability to propagate. So let's say if a virus was killing 30% of hosts, God forbid, these kinds of crazy viruses are out there. So we have, unless it does that, then the severity part is kind of not random, but it can be the next variant could be more severe or less severe. So it is not necessary that the virus will directly evolve into a less severe per case basis. So as you build immunity, and if there is less evasion of the virus, there may be an equilibrium that fewer people are getting it, and new variants are not emerging as frequently or are emerging at a predictable level. But if you look at the severity, it could be less severe or more severe. So that's a not so reassuring news, that we may have a virus with the infectivity of Omicron but severity of Delta.
So the waves or their peak may be higher over, depending.
Yeah, or the relationship between cases and hospitalization may be more pessimistic, etc. So hopefully we'll settle into a pattern that there's enough immunity through infection and vaccination where the possibility of the total number of cases will not be as high, the peaks will not be as high. So therefore, even if the relationship between cases and hospitalization and deaths is less favorable, we should be okay at a population level. But that's the hope.
I see.
But that does remain. So I'm not going to hide the concern about variants that are more infectious, but also a little bit more severe.
I see. And is there usually a correlation between severity and infectiousness?
That's what I'm saying. Yeah, no, unfortunately, no, unless a virus kills a huge amount of its, like huge, not just amount, proportion of its host, and which this virus is not doing. The reason why it's causing havoc is that it sits in that, unfortunate quote unquote sweet spot where it's propagating. It's not killing most of the people, thankfully, but then so there's this ability to propagate.
Right, and from the virus's perspective, that's evolutionarily like what its peak functionality is, right?
Yeah, no, again, so there is, that's a simple, that's why I'm trying to stay away from that intentionally formulation that the more infectious virus is less severe. No, that's a more, there's more to it than that. So infectivity goes up either through natural infectivity or evasion of the pandemic, evasion of the immunity through vaccination or infection, but severity can go up or down.
I see. Well, a lot of the questions that are coming in, not surprisingly, is when is this pandemic going to end? How do we even, where do we even begin in terms of benchmarks for how do we know what the end looks like?
Well, so here's the thing. We do know that this will become endemic for the foreseeable future. And because of the fact that gradually, either through vaccination or a mix of vaccination and infection, enough people at a given time will have protection that the number of cases, the number of peaks will not be as high. So that's how it will settle into a pattern in the next few years. I can't tell you it will happen this year, this fall or winter. I can't tell you it will happen next one, but I can on average tell you that in a few years, it will settle into a pattern. And it will be a situation where it is not that people like myself are worrying about it on a daily basis, but people like you or most of you will not have to worry about it on a daily basis. Obviously, what your actions are likely to be is to get, and we are looking at least an annual booster for most people, most adults, even moderate to high risk adults. That's what we are looking at. So I think we should be mentally prepared for this. This wasn't a given last year. It has, but the data point to that kind of a situation, but that's not the end of the world. It's like sort of getting a shot, which is increasingly, we know that vaccines that have come out, the data from the Chinese vaccines as well as the US and European vaccines have been very reassuring in terms of safety. Although there are differences between the number of doses that we may end up requiring, but that's normal for all sides of vaccines. So annual boosters is not, too high a cost to pay for sort of sustained protection. So that's what it's looking like. So it's not going to go with with a big celebration in the sense that one fine morning we find out the virus is gone. It will diminish in its ability to impact daily life. Unfortunately, it may still continue to cause morbidity and mortality, death and disease, but not at the numbers that halt daily life. But that would mean that people like myself will have to continue to fight this virus to get it further under control. But we are likely to get to an equilibrium where it's not impacting daily life, not because people stop thinking about it, but because it's at levels especially death and hospitalization at levels which do not concern people and governments, etc.
And just to clarify, that seems to be with pandemics that we've had in the past in history, that also seems to be the pattern, where it's not that these diseases are no longer around, it's just that they're no longer around to the point where it's affecting our daily lives.
Exactly.
Great. So you mentioned that the most likely need for annual boosters, and so it would be, at least in the US, it would be similar to us getting a flu shot every year. I have observed that in some countries the flu shot is not something that's given for various reasons. So in
which I think it should be. I think it should be. That's a difference, especially for, at least for some populations, at least for the very young and the very old, I think, and the pregnant women. I think that should be, because that helps us prepare for actually a flu pandemic as well. If people are used to getting that, it protects them against seasonal vaccine, etc. But we will have to, this is one of the things, this will be the cost of going back to normalcy, is to build an adult vaccination system of boosters, at least for the next few years, for boosters, against COVID-19. Sorry, I didn't mean to interrupt.
No, this is great. Because the next question then is, you mentioned at-risk populations, and I remember actually in the beginning of the pandemic, with the first wave and the first variants, that children seemed to be pretty much okay, and that they wouldn't really be at risk of getting COVID at first, or at least have symptoms of it. And it seems that over time that children have become more and more susceptible, I guess, to COVID. Is that observation true? And what is the difference between, the earlier, children being able to get COVID versus now, and especially because we have a lot of parents on the Zoom, should they be worried?
So here's the thing. So from very earlier on, from very early reports from Wuhan and China and other parts of China, it became, that was again an important piece of data that the world learned, that there was a huge age differential. And this is again one of those things. Initially, everyone, including the scientists who reported with caution, saying that it could be that there are differences in other risk factors, comorbidities, and not just age, etc. But it became fairly clear very quickly, based on subsequent data in China and in the rest of the world, that age was a huge factor. And so, having said that, it was never, as data became available, that COVID is less severe in young children than older people, but it was still more severe than other normal respiratory infections. So it's a matter of comparison. So those of you who took economics, it's a matter of counterfactual. It's a matter of your comparison group. So if you're comparing children to older people, and that's been true from the beginning, they get impacted less, especially it was unclear in terms of acquisition, but it was certainly true based on, once they get it, what is their what is their outcome, disease outcome. And so based on those data, we can be fairly confident and say that this is a situation where children get impacted less in terms of severe disease compared to older people. But if you compare it to other respiratory infection, it is more severe in children when it comes to COVID-19. But for some of the subsequent variants, especially Delta and Omicron, that severity has been a little bit more ramped up. And one of the reasons why the proportion of children in being admitted in other countries has gone up, as one of the reasons, I described the other reasons as well, is because as you have protected the elderly through vaccination, And through, unfortunately, infections, you are, that contrast has gone down a little bit. So this is the nuance that we are looking at.
So I guess then the next question is sort of looking at Omicron specifically, because that's the variant that we're dealing with now. What do we know in terms of incubation period and how long we're contagious for, and those basic stats? Has that changed over time with the different variants? And of course, the science is continually evolving as well.
Yeah, so there are a few things that have changed. First of all, our ability to, so again, you need a higher number of cases to get more certain evidence, etc. One of the things that became clear in 2020, not right away, was the importance of super spreader events, in a sense that in dense situations and populations, both because of social factors, because there's certain kinds of things where, for example, when there's a lot of speaking and loud talking going on, there isn't a lot of ventilation, but also because of host factors as well, that some people have higher viral loads compared to others, potentially. The average transmission is, the average transmission is only looking at the surface of it, that looks at a huge distribution of it eventually translates in practice to a few people transmitting a lot of infection. So the importance of super spreader events. So that's become more clear. The other thing is that we know that with Omicron, the time from infection to developing, to testing positive is shorter. So it used to be 4 or 5 days. Now it's 4 days with Omicron. We know that the viral loads go down quickly and the things are cleared quickly if you're vaccinated compared to unvaccinated. So we know that. The other thing is that a lot of countries, based on striking a balance between policy and between the ability of the workforce to go back to work versus keeping people safe, shortened their quarantine requirements. So the UK did that in the US, and I'm on the record to say that for countries based on their circumstances, it's okay to do that unless, provided they do testing, rapid testing, to get out after beyond 5 days. Unfortunately, in the US, the recommendations is wishy-washy about 5 days and beyond in terms of testing. So, but I do recommend that if people get infected and they're isolated, or and so therefore they want to end their isolation after, don't do that at before 5 days. And if you want to do that after 5 days, you test to get out of isolation. But it depends on public health policy of a region, because there are considerations about what is the population density and what are the implications and all of that stuff. But where there is a policy of allowing early end of isolation, it doesn't make sense to do it without testing between 5 and 10 days. After 9-10 days, it's in those situations where the policy is to have shorter isolation periods, people can, you don't need to test beyond 9 days. And this is rapid test. And just to give you an idea, just to clarify why I'm saying rapid tests or antigen test for this specific purpose, is that PCR tests are pretty solid, and they are the gold standard for therapeutic reasons. But for public health reasons, a rapid test tells you whether you are infectious or not. PCR continues to be, and understandably continues to be, positive beyond when you are infectious, but you still have the infection yourself. So there are two different things. Isolation is associated with your ability to infect others rather than you having the disease. So PCR is telling you whether you have the virus, and a rapid test, antigen test, is telling you whether you're transmitting or not. So these are the differences between the tests.
Right. And I think that's a very important distinction to make that I think is not necessarily out there. So just again, to clarify, there are two types of tests. There's the rapid test, which tells you whether you are capable of infecting other people. And then there's the PCR test, which tells you whether the virus is inside you, but that does not mean that you are necessarily going to infect other people. Is that correct?
Yes. And you continue to, so for there, you look at the overall population level recommendations and what is the probability of you infecting others, and so on and so forth. And the other thing is, it's a bit of a misnomer. In countries like China, PCR testing has been made pretty rapid by reducing the turnaround time
Right.
in a lot of regions. But that's the general terminology that is used.
Sure.
And rapid
And just to clarify, let's go behind the science a little bit. So what are the difference between the two tests? What exactly are we looking at?
So without going into too much detail, so rapid antigen tests, sort of rapid tests look at your, I'm struggling without sort of keeping it general versus,
Right.
while providing
Getting into the nitty-gritty, yeah.
Yeah, so rapid tests, in practice, have usually work better if there is a replicating virus. And PCR can work with even remnants of a virus. That's the practical thing. And so rapid tests are not culture, but de facto, they work when there is more virus. And so therefore, if you have more virus and your virus is replicating, you're more infectious. And so that's why we use it as a sort of a rough marker of infectivity as well, as sort of you being positive. And PCR is more sensitive in that sense, that it even detects remnants of a virus.
I see. And you mentioned viral caseload. So is the general data right now pointing to 5 days being sort of a big drop off in terms of viral load?
Yeah, so 5 days, but I think there is still in the population up to 8-9 days. So therefore, I thought it was better if countries were going to have reduced isolation was not to do that without testing. There's still significant proportion of people who are infectious. And there are data from, for example, NBA, the National Basketball Association, studies. I don't know if you guys know that in the US, the NBA was very at the forefront of collaborating with researchers, some from Yale, on these studies to look at how things happen, how this is transmitted, what is the value of tests, and how long people are infectious and that kind of stuff.
Right. So then with and that's regardless of whether they still have symptoms or not. So if you get infected, after 5 days, regardless of whether you still have a cough or whatever that may be.
So that's a good question.
Is there a direct correlation between viral load and symptoms?
Not a perfect correlation, or not as because your symptoms are often how your body is responding, not what the virus directly is doing. So so obviously your body responds to the virus, but people respond differently to the virus, etc. In terms of ending isolation, currently CDC that sort of has a somewhat mixed message on testing after 5 days. The US CDC also talks about improving symptoms. If your symptoms are not improving, then you should probably stay in isolation. You should continue to stay in isolation. And so, because it may be, even though the correlation is imperfect, it's not non-existent. So it's a bit of a nuanced picture there. But it's not. So if you have symptoms, and especially if they're improving or not getting worse at 5 days, it's probably your body responding to it, not necessarily that you're infectious, meaning your ability to infect others.
Very interesting. So then we've talked a little bit about the immediate symptoms, but of course, one of the things that people have talked about a lot and are worried about are the long COVID, right? Long-term effects. of COVID.
Yeah.
Do we have any more clarity in terms of what causes some people to have long-term effects and what doesn't? And I guess also just what are the long-term effects potentially?
Well, look, this is a virus that is quote unquote considered a respiratory virus, but it impacts the whole body. It's a pretty, especially amongst the unvaccinated, it's a pretty substantial body blow. So it's not your usual influenza, seasonal influenza virus. That's absolutely not the case. And so it impacts multiple systems, your neurological system, your cardiac system, and because of some of the sort of the secondary effects, for example, you have clots in your blood vessels, so they go everywhere. So all sorts of things are impacted by this, even in the acute disease. After certain viruses, there are syndromes that are, this is not new, that some viruses cause long-term sequelae, etc. But this virus, because of the fact that it's been so widespread, because nobody had immunity to start with, especially before vaccination, we've seen long COVID in pretty substantial numbers, if not proportion. Not everyone gets long COVID. And we meaning the scientific community, is still in the process of, first of all, we know that it happens. So long COVID is real, obviously. There's substantial evidence that it happens. At what proportions and what are the risk factors, we're still studying that. Because remember that you'll have to have some period past long COVID to follow up. And it's a pandemic where we are, all, it's the second, third year, this is the third year of the pandemic. Etc. So, and so people are coming up with cardiovascular, neurological, and some of the other syndromes that get clustered. And so one clarity would be that, obviously people, even without COVID, some people, as we all age, will develop something. So how much above the baseline is non-long COVID versus what they would have developed already will take a little bit of time to quantify the magnitude. We know that it has happened. We know at a crude level, it is happening at a higher level than people would be expected to develop some of these things. But how high, in what risk group, what is the role of vaccines? Early data indicate that vaccines, subsequent dose, if you develop long COVID, a subsequent dose can, very early data suggests, improve your symptoms. Is it true for all vaccines? Is it true for all symptoms? These are the things that keep people like myself employed, because there's so much to study that that's unfortunately we don't have all the answers right now.
Have we been able to at all sort of point to certain at-risk factors, either for just severity of COVID or long COVID? I mean, obviously there's old age and immunocompromised, but even with, you mentioned the NBA, right? There are certain players that seem to do worse than others, and as a whole, the NBA is, I'm guessing, relatively young and healthy and such.
Yeah, no. So first of all, that's been a humbling experience that even sort of people who are at the peak of their physical performance and physical ability can get it. But what is the, are they getting it at lower numbers? Certainly they're not. The indications are they're not getting it higher numbers compared to the rest of the population, but are they getting it at lower numbers? How low? That is being determined right now, because there are other sort of downstream things that are being clarified even now. And so we will figure this. It's not something that is unknowable. We have learned a lot about this virus. And in fact, we have learned about other viruses through a lot of the investment that has gone into this, studying this virus. But that clarification will come in terms of the magnitude. What is the different reduced or increased risk by underlying, and how, underlying factors, and how much it is different on top of your just likelihood of getting disease. So we know that the likelihood of getting COVID itself is highly differential by your comorbidity status, not just things like, cancer, etc., but also chronic kidney disease, obesity, etc., and all of that stuff. And obviously, age is the biggest factor. So it will take some time to tease that out. It will be teased out because there are enough scientific incentives and imperatives to actually do that. But we don't have a sort of a reasonably clear picture at this point, where we could say this level of risk is attributed to this, and so on and so forth.
Great. So I think we have a lot of more clarity now than we began with, obviously. I guess sort of as a last sort of question, so what do we know in terms of the science, in terms of what should we still be doing, and what do we need to make sure we're on top of, and sort of just what is the clear public health messaging that we need to get across still?
Yeah, no, first of all, it's, in our communities, individually as well, for a while, we'll have to have, first of all, vaccines are the mainstay of control. How many doses, what schedules, boosters, etc. Boosters are likely to be there, annual boosters for the next few years, at least. And so we need to focus on that, and we need to make sure that our loved ones, especially those at higher risk, are vaccinated. The second thing is we are in this together. So everyone around the world needs to get vaccinated, and needs to get vaccinated with the full schedule, whatever the full schedule is for each vaccine. The third thing is, while vaccines are a cornerstone of pandemic control strategy for COVID-19, vaccines, the more appropriate strategy is a vaccine plus strategy. And it depends on what's going on in the community, how much transmission is there, what are the risk factors, etc. So it can range from masking to all sorts of other things, ventilation and other stuff, and non-pharmaceutical measures. But it is pretty clear it's that at least in the short run, in the long run, we may be able to almost exclusively rely on vaccines. But we need to focus on that. The last thing is the global public health community needs to evolve with the changing data, with the changing variants, etc., and focus on what needs to be done under the current circumstances.
Great. Thank you so much, Dr. Saad Omer. We've learned a lot from you, and thank you for spending the time to clarify so many of these questions. Of course, this is an ongoing situation that continues to develop, and so I'm sure that questions will continue to come in, but thank you so much for providing the answers that you have so far. Per tradition, I'm going to ask everybody to turn on their webcam so we can take a group picture to celebrate our gathering of sorts. And I'm also going to unmute everybody so that everybody has the chance to thank you personally. Thank you again, Dr. Omer, and hopefully we won't need to see you too soon.
Thank you.
Thank you.
Thank you, doctor.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you so much.